Good morning, everybody. I'm Julie Moore. Until last year, I was Chief Exec of University Hospitals Birmingham, and I'm currently now doing, I think, as John nicely called it this morning, a portfolio career, because I find myself suddenly doing 8 jobs instead of the 1. But one of them is looking at digital health at Warwick. I've been interested in this all my life, and it's quite interesting to hear what's been said today, because I really do feel that you are all the converted, preaching to the converted, but some of the work I do with failing trusts, if you say to people about, let's think about a digital system, I'm reminded of Henry Ford's quote about, you ask people what they want, they'll say a faster horse. And so people actually want a digital system to stop paper writing, but see no potential in what you can use the data for, or how you can extract information to both for patient benefit, but also to make life easier for everybody. And so it's quite interesting as I go around now and can listen to everything going on here and realise the huge potential we have, and then see other parts of the NHS are just not ready for that. So one of my questions is going to be to our panellists later on, how are we going to spread this to the rest of the NHS? Because where we've had national schemes like Connecting for Health hasn't exactly worked. But as Dido said this morning, she's an optimist, I'm an optimist. I think this is one of the best times in my memory of looking at digital health. I think we have a plan that makes sense, it's being led by the right people, and it's starting to really deliver for patients that we're looking after. I think it is a great ambition that we can be global leaders in this, because we can. So I'm really pleased to be here today. So I have noticed that I seem to have the most complicated chairing session, because we're going to have 3 speakers coming up, one after the other. Then we're going to have a panel discussion of another 7 people. Can I just ask, I've been asked to ask the 7 people, if you could come up and sit in the order your names are listed, because that's how your slides are going to come up. Or you may have the embarrassing situation that Andrew and I once had at the Olympic Games, where he was talking to my slides and I was talking to his. And we did a good job, but we knew the difference. So that would be it. So it's my great pleasure to introduce Bryan Williams, who we've met before on several platforms, from University College London, the Biomedical Research Centre. And he's going to come and talk up about the value of data. Thank you.
Thanks, Julie. And I'm also an optimist. One has to be. And I'm going to talk about this from the perspective of somebody who is working in a major organization trying to deliver it. And in many ways, some of the challenges that we're facing have been articulated this morning, but I hope what I have to say will put some gloss on it from a perspective of delivery in the healthcare system. When I first started to look at this, I quite like this quote from Samuel Taylor Coleridge, because I think it sums up where we are. 70% of the Earth's surface is covered by water, but only 1% is accessible to use, to drink. And you could say the same about NHS data. There's a lot of it about, but it's all in different levels of quality and curation, and it's very fragmented and siloed. And that is a real challenge, and I don't think it's a challenge that is widely appreciated externally. We also see these quotes: the most valuable resource in the world, surpassing black gold. This was from The Economist. It was mentioned this morning that data is the new oil. Well, there are some similarities. Oil has to be extracted and processed before you can use it. And oil has some benefits and also potentially some harms from its byproducts of use. Very similar to what we're talking about this morning. But that's probably where the similarities end, because data is much more complex, it's more durable, can be passed around in multiple ways and used for different purposes by different people, not all of them to the benefit of the person who originally held the data. And we then see this kind of statement coming out of Ernst & Young. And you can imagine, if you're on a trust board like I am, I've got to go there this afternoon, they get very excited when they see this stuff, because they're dealing with cost improvement programs, and they see this as a potential solution to the challenges the NHS faces on a day-to-day basis in resourcing its services. But actually, if you look closely to what Ernst & Young said, which the press often don't, we've estimated the value that could be to the NHS, could be of 5 billion, and about 5 billion of that benefit is also related to improvement in efficiencies and services, which of course is way down the track in terms of the application of technologies that will improve health outcomes. So I thought I'd just summarize here how I saw the plurality and context of data. So many people view data in purely financial terms, and that's how the press presents it back to the public. But there are, of course, other values, and I'll just show some of them in a moment. These are efficiencies and outcomes. We use data already in the NHS to monitor our performances, and we try and use that data to improve efficiencies. But this could be more effective. Value, of course, is determined by who wants the data and what they want it for. They will put a value on it. They will tell you how they value that data. And as I've said, unlike oil, data is non-rival. It can be used for many purposes. And it's very durable. It's always there, and in fact, it grows with time. And so it's a resource that is enduring. But it's also contextual. And what is valuable for one purpose is not necessarily valuable to others, and that relates both to the type of data we hold in individual organizations, but also the quality of data. For epidemiological purposes, as we've seen, very large data sets from CPRD are suitable to look at relationships between risk factors and outcomes. But for clinical trials, the data needs to be an order of magnitude greater in quality to be accepted by the regulators as a proof of concept of a new drug. And as we've discussed this morning in some really, I think, enlightening discussion, the public value data very differently to what others might. They value their privacy. And one thing that wasn't mentioned this morning, they value the confidentiality of the doctor-patient relationship. Yesterday in my clinic, a patient said something to me that struck a chord this morning when I was listening here. She told me something. She said, "I'm telling you, doctor, I haven't told my husband, and I haven't told my family. And I don't want you to put it in the record." Because it was private. It was relevant to the clinical condition. Now, can you imagine if public lose trust in how we manage data? That patient-doctor relationship, that confidentiality, which is so critical to understanding the real problems underpinning many diseases, will disappear. So we have to protect that, and that's really valuable and important to the patient. And of course, they value, as we heard from the work done by the Wellcome Trust, the potential to translate data into improvements in healthcare efficiency, safety, and outcomes. But what we haven't discussed is the fact that some organizations, including health organizations, see data as a complete liability. They're particularly when it's personal data. They're frightened of being fined for breaching data confidentiality. I remember when GDPR came out, we were compelled to go on a whole variety of courses by our various employers, university, NHS, often not in the context of teaching us about GDPR, but about protecting the organization from data breach. That was the primary purpose of the education. And we must understand that there are people in organizations who do not want to release the data because it makes their life difficult. And we have to convince them that this is a useful use of data. Now, I just thought I'd put up here quickly the high-level principles that we are using in our organization about data. We sat down with the board, we've talked to lots of people. How do we want to present ourselves in terms of users of data? And the first principle was to put the patient at the center, and with appropriate and proportionate and transparent governance in the use of data. All the same things we heard about this morning. And put patient benefit first above all other priorities, including financial, always prioritizing a medium to long-term view, not a quick dash and run for the cash. We want to be a lead player in this space. We've got a lot of talent working in these areas, focused on long-term value creation and innovation. We don't just want to be a seller or a processor of data. And we want to be focused on real-world translational impact above purely academic endeavors. We're not interested in publications. Well, we are, but we are more interested in delivering real-world benefits. And we want to be collaborative, providing the people we collaborate with share our values. and share our principles about the use of data. And this is all a bit warm and silky, but the reality is it's important that an organization sets out its principles about where it wants to go. What nobody has really talked about in terms of the value of data is the cost of data. And there's nobody prepared to pay for this at the moment. And as recently published in The Lancet by Aradazi's group, they summarized it here. Estimating the cost of creating, collecting, curating, maintaining data systems related to the management of the data sets that people want to access is quite a good way of estimating how valuable that data might be. The cost is likely to amount across the system to several billions of pounds per year. Putting into context, what's only been mentioned so far is the profit. But actually the cost may exceed that in real terms. Technology in primary care, NHS trusts hundreds of millions per year to maintain. NHS digital budget, 400 million, although obviously not all of that is spent on what we're talking about today. So the cost of producing data is huge, and it doesn't always mean it's valuable either in the context of what we have been talking about. The value is created by making the data curated, accessible, and readable. And that is where a lot of investment needs to go. And at the moment, people are looking to invest in the sort of high-profile outputs, but actually we have chosen to make investments in the infrastructure. So in the Ernst & Young document, they produced this figure, which suggested that as you move from left to right, as you look, and you begin this process of data engineering and data collation and curation and merging data sets, that's where the value is created. Moving from a siloed, fragmented raw data system into one that gives us readable data with longitudinal accumulation and linkage to outcomes. So this is where most of the NHS is, let's be real. It has little digital maturity, many are digitally naive, and very little analytical maturity. Now, we have recently deployed EPIC. Now, I don't know the full cost of deploying EPIC, but I know it runs over £100 million. How many NHS organizations have got that cash in their back pocket to deploy an electronic health records system? Now, what that's given us is digital maturity. Although there's a lot of criticism of EPIC in the system, I use it. I love it. I think it's fantastic. It's made my life easier. It's made the patient's experience better, and they can interact with us through EPIC portals. It's really wonderful. And it's also given us some analytical capability. But that's not enough if we really want to leverage our data. And we've had to invest and create, through millions of pounds of investment, a clinical research informatics unit involving our information services, our digital services, our computer science at UCL, and AI partners. And what I've presented to our board is that you've bought EPIC, but actually, if you go and talk to the United States organizations that are on a par where we want to be in terms of both academia and clinical service, they all had to build a sidecar to EPIC to pull the data out, put it into a readable format, make it accessible and shareable with other systems. So because I'm talking to the board, I have to present it in this way. As a motorbike, which is EPIC, and the sidecar is what we needed to build. And we were very fortunate that we have some fantastic infrastructure architects available to us at UCL and UCLH who've allowed us to build what we've called EMAP. It's Experimental Medicine Applications Platform. And the idea here is that we move all of our data real-time out of EPIC, convert EPIC into HL7 messages and a readable system that is readable by everybody. We create a warehouse. We then have proportionate data privacy engineering that allows us different levels of access depending on what people want to do with it. We've also developed natural language processing systems that allows us to extract free text data and export it into EMAP, and appropriate data governance, security, and access control. This will allow us to plug in AI algorithms and also access supercomputing. Now, the important thing here is that we're creating a system, which nobody's mentioned this morning, of code to data. So what we're actually trying to do is not move our data out, but move the applications in so that they can work inside a much more regulated structure and access the data to develop and test algorithms. So the advance here is not the collection of more data, but actually the application of advanced analytical methods in well-curated data available in real time from 1 million patients a year accessing this healthcare system. And what you need to put together then is you've got Epic at the bottom, you've got this data warehouse, which we're going to make available to any other organization that wishes to use it, so it facilitates the sharing of data. And you need supercomputing, because one of the things that's made AI so attractive and so exciting and so hyped up is not so much developments in the fundamental mathematics of AI, but actually the availability of supercomputing power so that it can be used in real time within organizations. And so we're in the process of connecting UCLH. We're very lucky that UCL has a supercomputing cluster with 3 petaflops of computing power. So we'll have a hospital that has access to that computing capability, which again provides an enormous resource. But this doesn't come free. The computer supercluster, £12 million. We can connect for free, but others would have to have access in other ways. The point I'm making is the infrastructure costs here are substantial. The commitment to the organization is essential, and you need to be able to access a whole wide range of skill sets. So this is what we've built in 2 years. I had no idea about any of this. It's been a steep learning curve for me as Director of Research at the Biomedical Research Center. But we have 4 work streams, an informatics architecture work stream, building the infrastructure, a data governance and concierge service that allows both external partners and internal users to gain access in a proportionate way. We're developing an enterprise partnership group involving our finance and contracting teams so that when I get my daily emails from industry partners wishing to come and use the data from UCLH, I can direct them to a team who can deal with them professionally in terms of understanding what they want and what our capabilities to deliver are. And of course, we're trying to plug in AI science so that we build analytical platforms. And this involves the cooperation of a new directorate of digital health at UCL with a medical director in digital health. Not many NHS organizations have those. The corporate information systems, the BRC that's funded a lot of this, and of course UCL. So let me finish with a word about the frustration. Apart from the frustration of trying to get this thing moving faster than it does. And that is what we've already heard about this morning. And I just wanted to say a few words about this. I'm not a Guardian reader, but they're the best one to download for free. But basically, these are the kind of headlines that you wake up and you look at that and you think, oh, no, why don't these guys get this right? You know, the reality is if you're holding a meeting of senior leaders, it is going to leak. So let's get some information into the public domain in advance of these meetings to explain its context so it's no longer newsworthy. If you look at the merger of Ascension, or Ascension selling its data to Google, that caused a major storm in the United States, the Wall Street Journal. 1 month before, the Mayo Clinic had transferred all of its data to Google. There was no mention in the newspapers, because the Mayo Clinic had informed everybody well in advance what they were planning to do and actually told everybody why they were doing it, and everybody thought, that's a good idea. But with Google and Ascension, it was released under freedom of information. So basically, a reluctance to talk means front-page headlines in this space. So it's a faltering conversation, and it's a conversation that I was pleased to hear so many groups working on, that we have to win this this media conversation, this social media conversation, if we're going to be able to deliver on the prospects of the value of data. And let me finish with this. So if you go to many people and talk about the value of data, they see this. They see value as money. That's how many people view value. But actually, I like this vision that has come across today, and actually it aligns very much with what I prepared in my slides, talking instead about the values of data to the community. a value-based healthcare system with lower costs and better outcomes, better patient satisfaction, better efficiencies, better cost control and regulation, better alignment of prices and negotiation, and an overall better outcome for patients and society, but also societal and economic values, GDP growth, UK PLC, and of course delivering on the vision of the NHS. And finally, the values of the public, which are different, as we've heard today. They value trust, they value privacy, they value transparency. They want to know what on earth you're doing. And if we do all this, then I think if we sell this as the vision, then I think all the work everybody's doing in the background to try and build the systems that makes the data available will reap real benefits. Final case, an example. This is UCLH, has the National Hospital for Nervous Diseases. It has the largest collection of brain MRI images in the world, 100,000, all of them reported by leading experts in the world, linked to outcomes. There is no other data set like this in the world. It's de-identified data. It's being used to develop algorithms to diagnose brain conditions, but also enable reporting in district general hospitals that is of the same quality as you would get in a world-leading centre. The cost of the imaging alone with reporting is about £80 million. We've had disputes internally because people want to use this data, create spin-outs, and build algorithms to do all this work. The question is, what is it worth? How do we deal with that negotiation? Who has the capability within the NHS to lead those negotiations? And I put this case in to illustrate the point that there is a huge skill set needed in commercial discussions, but also to ensure that the NHS does get some value return on the investment that it's made in creating this kind of resource that is almost unique in the world. And that's why I liked, in my last slide, this summary from the paper that was just published in The Lancet, which was circulated in advance, this concept of a value-sharing mechanism for health services, discussing the ways, and I see James O'Shaughnessy's in the audience, and has been talking about this concept of the golden share and the various ways in which the healthcare organizations could benefit, but making the point that there isn't a single solution, that the quality of data and how much work and the cost of the commercial partner will need to invest is part of that negotiation. What kind of end product is produced? How much of it relies on unique NHS data and other assets? What is the NHS's unique inventor contribution? And what is the contribution and the skill sets provided by the partner? So this will differ on different bases, but you can imagine, as we get bombarded with people wanting to have these negotiations, this is a complex space, and we do need some national leadership to deliver this. So that's I'm going to finish there. My last point was just to make the point that somebody mentioned earlier about trade-off. Remember, there is good and bad of use of data. And the other thing that patients have said to me is that although you protect data, data could still be used even when it's de-identified to discriminate and could be used for unethical practices, for example, algorithmic profile and discrimination. Even though it may not discriminate against the individual person themselves, it could be used in ways that we don't want to see it used in the NHS, and we need to be careful about that too. So I think this concept of a data trade-off is also very important. Thank you very much.